Okay, so we are going to the next one. In sarcomas, surgery is the primary treatment, and for many sarcomas, it is the only curative treatment still available. However, too many of us have real-life evidence on what happens when the surgery is done before suspecting sarcoma. For sarcoma patients, the quality of sarcoma surgery is a question of life and death. I am happy to introduce our next speaker, Professor Jens Jakob. I don't know how to pronounce it in German, but anyway. He is a specialist in surgery, vascular surgery, and special visceral surgery. And he runs the Sarcoma Center in Mannheim together with Professor Bernd Kasper. And he is the head of sarcoma surgery section within the surgical clinic there. He is also active in the German Sarcoma Foundation. And for the audience, I encourage you to be interactive already during the slideshow, as Professor Jakob is hoping for interactive session this time. So, do we have him online?
I hope you can hear me. Hi.
Yes, we can hear you. Hello.
Perfect. That is very nice. So I apologize for not joining you in Frankfurt, but there are actually two reasons. The one is this one, which I have like 2 weeks ago, but that is not really a problem anymore. And the other one is that my daughter, who's a couple rooms out there, is COVID positive with symptoms, and so we decided to reduce a couple of contacts since she has the same vaccination that I have. So I didn't want to carry that to you. So I may give you my presentation, and I hope you can see that. Is that true?
We can see that, yes.
Wait a second. So now it should be full screen. Is that true? Okay, yes, I can see. So the title of the talk was Quality in Sarcoma Surgery. And I first show you my disclosures. So I got honorarium from some companies and some research funding. And I think for this talk, the most important disclosures are that I'm a member of the German Certification Commission for Sarcoma Centers and of the Guideline Commission, and that I'm one of the founding members of the German Sarcoma Foundation. And of course, when you look at the title of the talk, I could bring some information on sarcoma or GIST surgery itself. I have some talks held on that. And this is on sarcoma surgery, some slides, or on GIST surgery. The latter one you can see or hear, at least in German, on the websites from Sarcoma Day, from the German Sarcoma Foundation. But I decided against doing this, and I give you the background, and that I think that in general principles of sarcoma surgery and GIST surgery are quite well known, and I'll send you the presentations if you want. And I think expert surgeons may use different techniques and strategies, but probably their differences in outcome are small. I experienced it when I joined the really excellent colleagues at the Royal Marsden Hospital, and we compared data on extremity sarcoma, and those were quite the same in Germany and the UK if you use the same treatment strategies for at least for large extremity sarcomas. So it's not a strategy, it's more that you deal with sarcoma or GIST itself. And at least in Germany, where you don't have a very strong referral system, we have a huge problem with tube surgery and unplanned resection. So one of the real progresses we made in the last years that the certification system for sarcoma centers, driven by the German Cancer Society, was established in 2019, and there are right now 15 or 16 really certified centers which have proven quality in processes and in results. We have the guideline finalized this year and published, which is online. But we still have a lot of patients referred after hoop surgery, and the distribution of the guideline, the peer education is needed. So that is the background of this talk. And I just held this talk 2 weeks ago in front of like German surgeons in an online webinar from Berufsverband der Deutschen Chirurgen. And I just want to ask you for your support and join with you and ask you a couple of questions. So it was designed in German, and I apologize if that's never perfect, because with this it's a little bit difficult to redesign it. And but still we need to shorten it. So if you say some slides to be kicked out, just tell me, or tell Michi Geisler, who's on site, and if you say this is going out, we're going to take that out. The same is true if I miss some information, please tell Michi or tell us. We put it in. So kick out some slide, limit mistakes. Do not hesitate to interrupt me, and apologize for any mistakes. It's just technically was a little bit different and difficult. Okay, in German, you would say this talk, which was supported by the Niedersächsische Krebsgesellschaft, which is a state cancer society, was called Bildbord Biopsy, just because of the nice sound of the bees. And the Bild is not only a famous, let's say, news, not really paper, but news source in Germany. You would say it's imaging board, and biopsy, how to diagnose a sarcoma and to avoid loop surgery. So we have 3 learning objectives in this, and the first is the size of the golf ball, which is 4.2 centimeters in the metric system. So we probably have an improvement in outcome, at least local outcome, of 10% if patients are discussed in a multidisciplinary tumor board before treatment. And there's a risk of needle tract seeding, probably of 0.37 or at least less than 1% of core needle biopsies. And the gray number is not really a learning curve, and it's not what it costs to do all that, but it's what you save on money if you stick to those rules. So it's not a cost, it's not a red one, it's a green number, the 3,700 euros. At least it's an estimation. So of course I stole this one for Sarcoma UK, and I'm really thankful. It was this is a perfect thing to show, is this sarcoma? So my congratulations, and I hope I may use it. If your lump is bigger than a golf ball and growing, think sarcoma. And since in Germany you would say golf is, the German would be dekadente Sport, I'd rather say I'd refer to table tennis. And you see table tennis ball is 14 millimeters, or if you rather like other comparisons, you take a walnut, although a walnut doesn't have really a, let's say, C certified size, but it's around 2.5 to 4 centimeters in size. So please remember that all over. And but that is the basis of a really, really good paper from the UK and from Mr. Grimer's group. And they just sought from the referral system in the UK, what are the most important symptoms of a sarcoma, which is size above a couple of centimeters, pain, increase in size, and the location deep to the fascia. Being the most important, the size and increase in size. And then you can give a really good guess what's the malignancy and what not. And these were numbers and referrals from general practitioners. So you see, these guys are not, let's say, informationless or whatever. They have a pretty good sense what's dangerous or not. And if you sense something could be dangerous, you should treat it like a dangerous lesion. So size and increasement in size is the most important information. And the most important mistakes from surgeons are that you believe this could be a lipoma. And at least an ultrasound and an MR, and we have one ultrasound picture here, which is from a German lecture book, and we have an MRI here from one of an MRI for one of our own patients, which both show lipoma as a very homogeneous lesion And so the typical appearance at the superficial of the body. The second lesion, which is usually operated on right away, is suspicious for hematoma. And I took this from Emory University because they really had a really nice information. It was a direct blow to the thigh, which is hematoma usually occurs with a blow, with a trauma. Or it just happens if someone gets an anticoagulation or double platelet inhibition treatment for some other disease. So in the other picture, you see there's a retroperitoneal hematoma. This is not a tumor in sense of the malignancy, but in sense of a hematoma. So please don't treat lipomas and hematomas like sarcomas. So do not proceed to surgery immediately for lesions larger than 3 centimeters, which are growing deep to the fascia or symptomatic, and do not resect untypical lipomas or spontaneous or chronic hematomas. That is the first learning objective of this talk. So the second is planned surgery of sarcoma has better functional results than unplanned HOOPS procedures. There are a number of papers out there. And even if you only focus on what is the functional results, not only the oncological result, it's pretty clear. And I just picked out one publication, which very clearly shows, if you look only at the amputation rate on the right side, you see for planned surgery in this large series, it's 10%. And for unplanned surgery, it's 20% in the end. And there haven't been any real differences in disease before. So functional result is better if you plan things. The second is, and that was a paper from the French Sarcoma Registry or French Sarcoma Group, and it is very clear that sarcoma patients have a better prognosis if their treatment has been reviewed by a multidisciplinary sarcoma board before surgery. So if you have such a Kaplan-Meier curve for any medication for a tumor, I would guess that any health system in the world would spend a couple of billions to buy in the drug. So this is not a drug. This is a very simple procedure which says, please talk together with some experts, with someone who has experience in sarcoma treatment before you proceed to surgery. And this is a rough estimation of 10%. And of course, it's not a scientifically correct number, but I think it's a good estimation of what you win. So that is not only true for relapse-free survival, that may also be true for survival that is improved for patients which are operated by expert surgeons in sarcoma centers. So again, this is French data, and you see if you have a very well-working system of registries from real-world data, you can have really good information on our patients. So again, this Kaplan-Meier curve just shows in the green line patients which have been operated in expert centers, and the blue curve of patients that have been operated on outside these centers. And of course, there may be reasons for that people do not want to travel, that in very rare cases, you have an emergency. But in general, if you have the possibility to send someone for surgery in an expert center, you may consider doing this because it may have the better quality in sarcoma surgery. So these are data from Germany, not on sarcoma, but we do start to gather some data even there from real-world registries or from tumor centers, which have been certified by the German Cancer Society. That means this German word certification, yes or no. And this is a hazard ratio, which is not too high, but at least it does prove for pancreas cancer, for pancreatic cancer, what we all believe, that treatment and a referral center is better than treatment at any other place. And the most probable reason for that is that adherence to clinical practice guidelines is implemented in these centers. They do need to have some institutional report on what they do and how they proceed they've the standard operating procedures to say everybody goes to the tumor board. And that already has been approved like a decade ago. And at that case, that was funded by the European Union. And there were a couple of regions in Italy and France who looked at what happens if you stick to clinical practice guidelines, pretty much like build, board, biopsy. And that shows that survival is improved. This is over all stages. Of all stages, you say relapse-free survival was for all patients like 2.4 years if you stick to clinical practice guidelines. It was only 2.1 year if you didn't stick to them. And the number I told you in the beginning, which was quite similar to the 0.37% risk, there have been 3,700 euros saved in those patients who have been treated for clinical practice guidelines. So you save money doing that. So that is why the Lower Saxony Krebsgesellschaft Cancer Society funded this very small campaign for build, board, biopsy in Germany to implement the adequate therapy approach for any sarcoma patient in that state. So if I say there are the three things you need, like it's an image, it's a biopsy, and the multidisciplinary tumor board discussion, you say, what are the risks of that? So there's obviously usually no risk for tumor board discussion, and usually there's no risk for imaging for an MI, or at least they're very small. There's some risk for biopsies, and any procedure-specific complication can occur. That's usually a small bleeding, sometimes some infection. And this rate is constant in a lot of studies. It's approximately 1%. And what is much more often discussed with patients and families, and especially with colleagues and surgical colleagues, what is the risk of needle tract seeding? And I want to talk about needle tract seeding and about core needle biopsies. And this is from our own centers, like 400 outpatient biopsies. That is a procedure that is in the same procedures done at the Royal Marsden Hospital in London, or the Mannheim Center, or a lot of other centers. You just have a patient who walks in with a tumor, and you discuss, are we going to take the biopsy right away at this moment? And we usually do this under local anesthesia. We take the core needle biopsy, and we just looked at, did we have complications? Yes, we did have some complications. We really had to operate on one patient because we had an abdominal tumor, and we had a bowel perforation by the biopsy, and we had the pneumothorax, which means that some air is getting next to the lung, and we just need a small operation or a catheter put next to the lung to get out the air again. And another patient received antibiotic treatment, and no other patient had any complications. This is 3 out of 392. And 90% of the cases on an outpatient basis, we had histology was conclusive, which means we could plan for the future. We could say, this is malignancy, this is a benign lesion. We could very often say which type of lesion it was and how to proceed, and enable multidisciplinary tumor board discussion. So that was kind of the benefit and the risk. You say, what's needle tract seeding? And in gist, and if you heard the talk from Ewan Hout, he really had one of the best studies on that, describing what happens to patients where you do an abdominal puncture with a core needle biopsy in GIST patients. And he was the only one who ever described a needle tract seeding of a GIST patient in the last 20 years, at least in the literature. There may be other cases, but I think as a surgeon, GIST has become a pretty famous disease in the last 2 decades. And if needle tract seeding would have been a really frequent event, there would have been probably more reports on that. And Furthermore, post-hoc analysis of prospective studies show that biopsies do not have an impact on recurrence-free survival, at least no impact which is negative for the patient. It's usually positive because then you can plan for preoperative therapy and so on. So this is about GIST, and the same has been looked for retroperitoneal sarcoma. And I have those two examples because in these tumors, and you see on the CAT scan here, a tumor which is on the left abdomen, which has been reached by core needle biopsy, you can't really excise the needle tract. If you do an incisional biopsy on the extremity or core needle biopsy on the extremity and you go straight to the tumor, you can later on excise the tract you had with the needle. You can't do that in retroperitoneal sarcoma. So this is the role model for a core needle biopsy where you do not excise the needle tract. And even there, retroperitoneal sarcoma, needle tract seeding is a rare event. It's less than 1% from all we know in GIST and in retroperitoneal sarcoma. So that is one of the learning objectives, to say it's less than 1% the risk of a core needle biopsy for needle tract seeding. So biopsies of soft tissue lesions have a low complication rate of about 1%, have a high diagnostic value of about 90% to say this is malignancy or not, this is sarcoma or a lymphoma, which you would never operate on. And they have a low risk of needle tract seeding if it's sarcoma. But I can tell you from literature research, the same is true if you have like renal cancer or adrenal cancer, that usually needle tract seeding does have a low incidence. So histological subtyping is a prerequisite for discussion in sarcoma.
May I interrupt you? Sorry, there was
Yes.
a question in
Yeah.
the chat.
Okay.
Maybe somebody can read it from there. I can't see the chat, but there was a question in the chat.
So there were two. ctDNA is the first question, and ctDNA is an experimental technique for sarcoma. And there are some groups that try to diagnose a sarcoma by ctDNA, but it's still experimental, so I would not implement it in any talk if I speak about routine measures, what to do. Do you feel that AI will be valuable in all this? Yes, that will be, artificial intelligence will be very valuable. And I may come back to that in the end of the talk. I just had to skip a couple of the slides in the end. There are, for lung cancer and for other cancers, there are some artificial intelligence projects to screen the imaging of patients and to calculate the probability of a cancer or not, or to detect recurrence. I strongly believe that the same is true and possible for sarcoma patients. And for example, in the Munich group and the London group, they at least among others, work on how to apply artificial intelligence on imaging to say what is the subgroup of the tumor, is it a tumor at all, and even to say what is the grading of the tumor if you know the subtype, because that is a weak point about core needle biopsies, that the grading may not be as good as if you do it from the resected specimen. So there's a lot of space for research, and this is ongoing, but it's not routine. So I think I'll proceed. Is that okay? Yeah.
Yes, I think so. Yes.
Okay. So as I said, you have probably estimated survival advantage of roughly 10% if you stick to the rules. And that's the reason why I should say, if you have a complication rate of 1%, I'd rather take the 10%. So remember the 3 learning objectives, which is the size of a golf ball is 4 centimeters. And that is the size where you just should not proceed just to surgery, but should proceed to some imaging and to biopsy to enable a multidisciplinary tumor board. And if you're afraid of a biopsy, remember the comparison between 10% and less than 1%. And this procedure of multidisciplinary tumor board and biopsy may save the health system a couple thousand of dollars or euros wherever you are. So if your lump is bigger than a golf ball and growing, think sarcoma, and improve survival of your patients by imaging, biopsy, and expert multiple sarcoma board discussion before surgery. So thank you for this part, and please, any comments to the talk, because if you not, I just wanted to show you in the next couple of slides, I brought some pictures, how we would just proceed sticking to those rules, and what is the differences, and then we may come back in the end. I think I have it in the end here. This is one of the projects where you can talk about artificial intelligence. So I'll take any question right now before I proceed.
Is there questions here?
We have another one in the chat.
Okay.
If a patient has multiple recurrence over a number of years, is there any point to continue with CNBs, or does the consultant assume the sarcoma pathology remains the same?
Yes and no. First, I'd rather take biopsies in the beginning to prove it's a recurrence, and especially if it's not a local recurrence, but if it's a metastasis, I would always do so, because there are quite some patients who have new benign lesions or who do other tumors. So I'd rather take a biopsy of a pulmonary lesion than just to believe it's a lung metastasis, first. Second, there is a place for another core needle biopsy if you think about grading and to estimate your further risk and to choose your treatment. If you have a high-grade lesion, I'd rather proceed to chemotherapy than in low-grade lesions. So if your decision is to proceed to surgery or radiation or chemo, there's a definite place for a core needle biopsy to look at grading.
Okay, and I have one question. You were talking about the soft tissue lesions. How about bone tumors or chondrosarcomas? Do you know if there is needle track seeding or something there?
Yes. I can't put in a number, so I'm not an orthopedic surgeon, so I'm sorry, I don't have the number really, and that is true. So as far as I know, it's more frequent if you do not excise the needle tract. So the diagnosis of bone lesions are a little bit different. If I just wait a second. If I say you go, I'm sorry to be very fast on this one. If I go to billboard biopsy, that is very often what you do in bone lesions. You take a picture, which is usually an X-ray and an MRI, and then you go to the tumor board, and then you plan the biopsy. That is something that is established for a lot of bone lesions. And then if you go to the board, you usually decide that an expert orthopedic surgeon should do the biopsy. So I think the answer to that question is rather, if it's a soft tissue lesion, you can go more or less straight to a biopsy. If it's a bone or if it's a bone lesion, you should just, before the biopsy, go to an expert tumor board before you do it, because you plan the surgery with a biopsy.
Okay, thank you. And there was one question in the audience.
Yes. Andrea Bozzico, Orchestra per la Vita, Italy. We all know that 5 centimeters is a critical dimension for sarcomas. So do you believe that the message that you have to check only after 4 centimeters, it's a valid message? Would be better to say, please check with an ultrasound check if there is an issue with this sort of tumor, because we have several examples in our association where young patients have been initially sarcomas in the dimension of 2 centimeters, and unfortunately they died. So that's the question.
So with the for this talk, I stick to the 4 centimeters because I have a perfect, let's say, precedent with the UK sarcoma giving me the golf ball, and I have evidence for that. I can show if you take the 4 centimeters and the growing in size and the symptoms, it's either one. Then you proceed to a diagnostic algorithm. It is true that especially for young patients, that fast-growing dangerous lesions can be smaller initially. And so 4 centimeters might be too large, and we may put 3 centimeters. Another reason to do that would be that, and if I, sorry to be fast again, I have a slide in the end where I refer to the German, what we put in the German guideline. Of course, it's German, I apologize, but a small excision biopsy may be done in superficial lesions smaller than 3 centimeters. So in the final version of this talk, I'll probably take something which is 3 centimeters, because that is the German guideline that was designed for Germany. But that is what we agreed on. And I think it's quite reasonable to do that, yes. But you're true, there's some patients, especially young, where you should be very alert with those lesions, yes.
Sorry, do you think that ultrasound could help in these regards?
Yes, although you need to be trained in ultrasound of soft tissues, or even colleagues who work in, like, from my own experience, is that even colleagues that do work in hematology and oncology and who do quite frequently ultrasound of suspicious lymph nodes fail to just identify a sarcoma in the soft tissue. So ultrasound does need some experience.
Okay, thank you. Do we have questions? No? So feel free to talk us about AI.
So I may proceed with these pictures just to tell you how we proceed in our own practice, kind of why we say that. So if we talk about these sizes, this is an MRI from a 70-year-old patient who just had a discomfort of the leg, who just thought it was kind of strange thing. And you see this lesion has a 35 millimeter size. And this turned out on biopsy to be a myxoid liposarcoma. And that is a very important information, because this lesion is in the most important muscle for stretching your knee. So if you do large surgery, and especially for a 70-year-old or older patient, you would weaken the strength in the knee if your surgery is too large. And if you're myxoid liposarcoma, you would say, great, we could do some pre-op irradiation and downsize this lesion. So that is why biopsy at this point is very important. Even in small lesions, you can make surgery even smaller, because here pre-op irradiation can smother the size of your tumor. The second MRI is of a young patient, and that is what we just talked about. That is an MRI of a young patient which is not even 40 years old. The position of the tumor is on the back side of the thigh, And yes, we went for primary surgery, but we went into the skin, cut out some of the muscles, but with, I think, no functional differences before and after, and went out and did a complete resection right away, just as an excisional biopsy. And I can't tell you the histology of this lesion because a colleague of mine just did it 2 days ago. So you can ask me later what this was, but that was one of the tumors we just cut out because you can close the skin, you lose only very few muscle, and the risk of surgery is very low, and you get an immediate result after a couple of days from histology. So here it's harder to see, but there was another lesion of the thigh, and there was an 84-year-old lady. And with this picture, she underwent an oops surgery outside our center. That was really not nice for that old lady because they did an R2 resection, like a piecemeal thing. And we discussed with the family, with her, if he would redo surgery and go for irradiation afterwards, because you have to see, these are the muscles you need to take your knee straight and to take the stairs, right, at any place. And this is part of these muscles. If you go again to surgery, you have to reduce it by at all 50% and then do an irradiation. And we went to surgery and she does take the stairs, and now she proceeds to radiation therapy. But these are really hard decisions because, of course, you risk that this 80-year-old patient will not walk again is quite high. So we talked about lipoma, and this is the appearance of one lipoma, which is very easy to resect. But even lipomas as a benign lesion can be hard to resect because you can see this is probably the same appearance than the other one, but still you need to know some anatomy because this is sciatic nerve. And of course, you can't just go inside here because you're going to lose all movement of your foot if you just go down there. So even if you think it's a benign lesion, you'd still have to see if you want to do it yourself or send it to an expert surgeon. And what we talk about artificial intelligence, that is a perfect example because this is a CAT scan of a dedifferentiated liposarcoma. And I probably can say that as well as a lot of other sarcoma specials, just from appearance on CAT scan, because all the dark matter on the right side here is all lipoma-like lesion. It's all fatty tissue. It's one part of the tumor. And there's a second part of the tumor, which is here, or on the other part, which is here kind of thing. This another third part, which looks different. And what's the character of this tumor? Like a dedifferentiation. And it does, and of course, if you would train a machine to say this is dedifferentiated liposarcoma, that would probably succeed to get a good diagnosis on that. That would be a perfect case for that, yes. So this again is not a sarcoma. This is an adrenocortical carcinoma, but looks kind of the same as the other one, but it was just going from top down. This patient gets a really different chemotherapy than a sarcoma patient. So biopsy proves here to be very, very important for the patient to get it out. And this is one of the few lesions we did not put a biopsy on. And there was a reason on that, because if you look at this reason, it is in a vessel. Okay, this is in the vena cava, one of the largest vessels. So the few cases where you do not do biopsies, because if you do a biopsy right here in the vessel, you might just spread the tumor into the lung because you just do like a piecemeal thing to it. So that's one of the few things where we don't do a biopsy. And if you look at the artificial intelligence thing, I would say, what are we going to do in the future with imaging? There are imaging features like diffusion imaging, where you can compare images here from an intraabdominal tumor with histology. And you can guess how aggressive a tumor is. And this is an example where we put biopsies from this tumor and put some marker in the tumor, which you can see here. And then we went with the, after resection, we went to the CAT scan and do diffusion imaging to learn what is on the diffusion imaging here and what was on this and what is on the biopsy there. So we have a site-specific correlation of histology and of imaging. And this just goes for publication. And it seems like we can guess the grading by doing that. Of course, these are pilot studies and we can look at this. And this is not a perfect match of G1, G2, or G3, but at least that is the direction we want to go with imaging. And if you go there, that you could say that something like the apparent diffusion coefficient would show you what is the grading, then you can feed the machine with diffusion imaging from like hundreds from MRIs and say what was the outcome of a patient. That would be a very, very interesting project to proceed on. Okay, I think that's what I brought you. Thank you.
Thank you. Is there still something? Is there questions? Somewhere in the audience? No, not here. And the online is quite quiet already. I must say that we've been having lots of discussion about quality of life and PROs, and I think this quality of surgery is very important in those issues.
Yes.
As you mentioned that, for example, the thigh muscle, if it can be saved, it's massive thing for the quality of life. So thank you for your time and your presentation. And okay, Dennis has some question. So.
Hello? Oh, there we go. I have one quick question. In the United States, we were very taken by the Sarcoma UK golf ball project, and we've really struggled with who should we get the message out to, right? I mean, and sending it to oncologists, how do we help get this word out broadly? Because we do think it's a very clever way to raise awareness and it's something that's memorable. But we struggle, is it primary care? Is it, you know, do you have any suggestions and thoughts how best to leverage this really important message?
I think it goes to surgeons. It's my own profession. It's me and my colleagues, let's put it this way, because those are the ones who are doing the operations and which are now I have to think about if I'm allowed to say that, who earn the money with it. If you in Germany do an inadequate resection of a sarcoma, you get the same money that I get for the re-resection, more or less, although I probably have a lot more resources put in the case. So I think it's surgeons, and that's how our project is going to go. So there are, in Germany at least, some organizations like Berufsverband der Deutschen Chirurgen, which is just, and they're surgeons who are more or less doing only outpatients, and they've community together, and we are just trying to get into these networks and being very friendly, and at the same time being very clear in that a lesion which is larger than 3 or 4 centimeters should not be excised without any other diagnostic means before.
That's very helpful. Thank you.
Okay, I think we are ready to close this. Then we are early. 7 minutes to go. Are we having a break or are we going? Yeah, so Advocacy in Action Award. Who will be here? Denise, okay. Thank you, Jens, again.